Order, order. The committee is now in session. Can I start by saying to all of our witnesses today and those watching to put on record our gratitude to the wider science and research community for all of the extraordinary work done under incredible pressure and at pace that is being done right across the country and indeed around the world. We're very grateful, and alongside health and care workers and people in the public and private sectors and volunteers, the work that is being done is deeply appreciated by everyone, and we're particularly grateful for those witnesses who've taken time to appear before this committee today. Let me start by just saying something about the work that the committee is conducting. We will, as I'm sure everyone would expect, to be conducting an inquiry into the lessons, in particular as the Science and Technology Committee, for UK science and its role in government, to be drawn from the crisis. Manifestly, most of the analysis and conclusions will have to be and appropriately done after the crisis has subsided. But it is important to take evidence during the crisis from time to time, really for two in particular reasons. One is to be able to capture contemporary evidence of what is in people's minds during the crisis, to be able to review afterwards and not just to rely on the benefit of hindsight. And secondly, if there are lessons to be learned already from what has happened and that can be applied in real time, it's obviously very important that we should discover them and be able to reflect on them if that is the case. So that is the reason for today's session. Our first witness is Professor Neil Ferguson. Welcome, Professor Ferguson.
Good morning.
Thank you in particular for appearing, given that you have suffered from the virus. I hope you're feeling better.
Yes, improving day by day.
That's good. You had earlier, we caught sight of your mug, keep calm and carry on, and I think you personify that particular approach. Can I ask, was the experience as you expected?
I don't think I knew what to expect. It was like rather bad flu. There were a couple of days where it was really quite unpleasant, but I think I'm basically on the mend now. Actually, severe symptoms tend to happen in the second week, so I'm crossing my fingers, but I think it's basically over for me.
Good. Well, we hope it is. We hope the second week won't be as bad as the first. Can I start by asking you, Professor Ferguson, are you a member of SAGE, the Scientific Advisory Group in Emergencies?
Yes, I am.
And who are the other members? Could you just give us a kind of feel for what that group comprises?
So SAGE consists of other chief scientific advisors from government departments, and then a set of external members, including they're the head of subgroups of SAGE. So there's a subgroup on modelling, and chaired by Graham Medley from London School of Hygiene and Tropical Medicine. There's a subgroup of behaviour. Then there are specific individuals representing expertise in virology, immunology, behavioural science, and the like. I won't list all. I don't actually think I could remember all the members off the top of my head, but I would say there are probably 10 to 12 external members, and then a lot of people who attend meetings as observers.
I see. And all of the chief scientific advisors from every government department?
Yes, the meeting is co-chaired by the Chief Medical Officer and the Government Chief Scientific Advisor, Patrick Valance, but there is representation from every department and from Cabinet Office number 10.
Thank you. And how often does it meet as a full group?
It has been meeting twice a week since, I can't remember the precise date, sometime in January.
Thank you. And has SAGE presented unified advice to government? Has it formed a consensus? Or has it offered different opinions?
It will vary depending on the topic under consideration. So the aim of SAGE is to give the co-chairs the best scientific evidence and the uncertainty around specific topics. So we're not trying to reduce uncertainty, we're trying to convey to Patrick and Chris what is known about the science, what the uncertainties are, so that they can make a judgment about how they communicate that to ministers.
I see. And in your view, having seen the decisions that have been taken by ministers and having been on SAGE, would you consider that the government has followed the advice of SAGE?
So to be clear, SAGE does not recommend policy. SAGE makes judgments about science, good scientific evidence, including about how rapidly the epidemic is moving, what the likely lethality is, and not recommendations about interventions, but insights into what interventions might have what effect. So it is not, I'm not sure if the relevant question asking, has the government followed the advice of SAGE? The government, I believe, has been informed by the scientific evidence and has balanced that against other considerations, such as economic, health, and all the things you might expect it to.
Thank you. Are there any areas where there has not been a united view amongst the scientists on SAGE, and where it's been necessary to report a significant difference of opinion?
I think on key conclusions, no, but on lots of the details, yes. People have not so much taken different views, have emphasised different aspects of the science or the uncertainty in particular topics.
Could you give perhaps a representative example of that type of detail?
So, for instance, I mean, in the media today, you'll see reports of paper claiming that a large proportion of people may have no risk of severe disease, or there may be an asymptomatic pool which you're underestimating. So SAGE has considered that issue in a lot of detail. We have ruled out the sort of scenarios actually in that paper, but there is still uncertainty about the extent of asymptomatic infection. I would class that as not a critical issue because it doesn't really make any difference to what government response should be at the current time. Conversely, I would say in the last 2-3 weeks, the increasing evidence about both the growth rate of the epidemic, the severity and the likely healthcare demand has led to a fair degree of unanimity on SAGE about the impacts of the epidemic.
Thank you, that's very helpful. We'll come back to the particular study that you mentioned. Just referring to your paper and your colleagues' paper at Imperial of the 16th of March, when you concluded that mitigation is unlikely to be feasible. You said that in the UK, this conclusion has only been reached in the last few days with the refinement of the likely ICU, intensive care unit demand due to COVID-19. Could you explain why that modelling of the intensive care capacity was not available until that point in March?
So maybe I'll go back. So we, the London School, London John Edmonds Group, and NHS England, senior analysts got together on Sunday the 1st of March to review with clinicians and scientists the evidence around the severity of COVID-19. We had at that point come up with probably what is still the most definitive estimate of case fatality. That meeting was really to put that into a UK context and try and make an assessment of likely bed demand. We did that, and actually that day and the immediate days following that came up with estimates for NHS England and SAGE of the likely, therefore, profile of the epidemic in terms of bed demand and mortality. NHS England then looked at the potential for surge capacity of the following week or two, and that's quite an intensive exercise. I was not involved in it, so you will have to ask them. The one thing which came into play then, probably about 10, I can't remember the precise time, about 10 days after that, was it became clear from data from Italy and actually the UK experience that prior assumptions about intensive care usage we've made on the 1st of March, we're probably optimistic, and intensive care demand might be twice that we had anticipated. And the reason for that is that we had assumed that of roughly half the patients requiring ventilation with severe COVID-19 would be able to be ventilated general. Emerging data shows that that's issue gives rather poor clinical outcomes.
We're struggling a bit with the feed, Professor Ferguson, but we can still see you. So just repeat that last bit again, if you wouldn't mind.
Apologies.
No,
so
not your fault.
The revision was that basically estimates of the proportion of patients requiring invasive ventilation, mechanical ventilation, which can only be done on a critical care unit, roughly doubled. And so the combination of that and NHS England assessing how much they could surge led us to conclude that there would be no way that even with what we're now talking about, surging at least double normal capacity, if not triple, would be still insufficient to cope with an epidemic which was just mitigated, where we weren't going for full-scale lockdown and containment.
Thank you. I understand that, and indeed the peak, according to your paper, is that the peak would be 30 times the maximum capacity of the ICUs across the country. I think I'm right in saying.
So that would be an unmitigated. I think I don't have the paper in front of me. I think we concluded it was about 8 times in the sort of mitigated single peak epidemic, the best we could do. I should say that with what NHS are now planning to put in place, that gap reduces from 8-fold up to I think about 3-fold, but it's still a 3-fold gap.
So on the basis of the announcements that the Prime Minister made this week, you think that gap at the peak is about 3-fold?
No. I mean, so let me go back and be clear. So NHS, since we did that initial analysis, which came out on the 16th of March, NHS have refined their ICU surge capacity estimates. Those have gone up again, more than doubled. And that means the gap, had we followed the mitigation strategy, would have been less, but it would have still overwhelmed ICUs.
I understand. And have you...
In this current strategy being adopted now, we think that in some areas of the country, ICUs will get very close to capacity, but that it won't be breached at a national level.
So that's a very important point. So and that is a combination of the surge in the NHS provision plus the measures that the government announced this week that will, at a national level, on your modelling, be containable within the capacity of the health system.
Yes, there will be some areas of the country which are extremely stressed, but we are reasonably confident, which is all we can be at the current time, that at a national level we'll be within capacity.
Thank you. That will be tremendously reassuring to many people, although we do understand your caveats that this is based on predicting something that hasn't happened yet. Just a couple more points, then I'll turn to some of my colleagues. There is a perception that the approach that's been taken in the UK and has been reflected in the papers that have been helpfully published by SAGE is rather different from the approach that's been taken in other countries in the world, notably in Asia, but sometimes in the continent of Europe as well. And indeed, in the paper that was published in the bundle of evidence dated the 9th of March, the potential impact of behaviour and social interventions on the epidemic of COVID-19 in the United Kingdom, the summary view there was, and I quote, implementing a subset of these measures, these interventions, would be ideal, i.e. not the whole set. Whilst this would have a moderate impact, it would be much less likely to have a second wave. In comparison, combining stringent measures as a long-term policy may have a similar impact to that seen in Hong Kong or Singapore, but could result in a large second epidemic wave once the measures were lifted. Can you just talk us through why you think amongst eminent scientists in this country and around the world, quite a different view was taken on what was the way to manage this? And you obviously in SAGE concerned about this second peak.
Yes, so the background to that is that we were being asked to look at interventions which would, the optimal goal was to not have this country locked down for a year or more, and to balance mitigating the health impact of the epidemic against the economic impact and the impact on the NHS. And so, had it been possible to deploy extreme cocooning of the elderly, shield them from severe disease, and manage the epidemic such that it didn't exceed healthcare capacity, then there would be clear advantages economically to having it over by the end of the summer. That's the context where we were looking at a range of interventions which might achieve that. When it became apparent that actually there would be no way of managing the epidemic to the extent that healthcare demand in that first wave would not overwhelm the NHS, then we moved to, actually in some ways slightly reluctantly, looking at much more intensive strategies. I say a little reluctantly because, as I commented before, we will be paying for this year for many decades to come in terms of the economic impact.
Yes, I see. Thank you for that. And is it your view that the majority of the population will expect to contract COVID-19, or do you think that can be avoided?
So with the current strategy, no, we don't think that would be the case. The aim of this strategy is to suppress transmission really, frankly, indefinitely until we have some other countermeasures to put in place, particularly vaccine. The challenge with it is, if in some sense we allow a significant fraction of the population to become infected, we're back into the scenario of an epidemic which the health system cannot cope with.
I see. And so the difference between, as it were, the UK view, or the SAGE view, and other countries is about the capacity of the local healthcare systems to manage to absorb the pressures during the peak.
I think the strategies are fairly aligned at this point. I think the UK, more than, not all countries, but many countries, did intensive assessment of whether alternative strategies were possible in terms of avoiding the country needing to be in lockdown or equally effective measures for a very long period. We concluded obviously that wasn't possible, and therefore actually the strategy we're in now is rather similar to many but not all other countries.
Thank you. And a final one from me before I hand over to colleagues. What was notable in the bundle of evidence that was published is that a lot of the work of the advisory group, insofar as the evidence published reflects that, is around these social interventions, distancing, closure of schools, etc. Comparatively little to testing and contact tracing, which has been foundational to some of the other approaches, as you're aware. In fact, the evidence includes a couple of quite striking papers that point to the importance of that as background papers, but they don't appear in the report of the deliberations. Is what's been published a fair reflection of what has been discussed, or did this have a more prominent place in the discussions?
Testing has always been discussed significantly. The reason it wasn't included in initial modelling was the projections by PHE of how quickly this country could ramp up testing capacity. We're looking at, so if we have to transit from this suppression strategy and the lockdown strategy into something this country can maintain long term, undoubtedly testing much more widespread testing, contact tracing and other methods will have to be deployed. If we're talking about back in January, February, early March, it was very clear from messages from Public Health England that we would have nowhere near enough testing capacity to adopt that strategy.
And that informed the discussions that took place in SAGE? Thank you.
Yes.
When do you expect the peak of the epidemic to be? Have you made a projection of that in your model?
Yes, I mean, it's something we're working on intensively this week. If, and it's an if, we're moderately confident, as I said, but can't be completely sure. If the current measures work as we would expect them to, then we will see intensive care unit demand peak in approximately 2.5 to 3 weeks' time, and then decline thereafter. The reason for that lag is because it takes people something like 2 to 3 weeks from being infected to actually being in an intensive care unit. And so the measures put in place last week, intensified this week, we think will have had a significant effect on transmission, but it takes that time for it to propagate through to healthcare demand.
I see. And how many people, either as numbers or percentage of the population, do you expect to be affected by COVID-19, say during the next 6 months or whatever interval is the most appropriate to consider?
It's a very difficult thing to assess precisely at the moment based on current data. It will vary a lot by geographic area. It's possible that up to 5 at the outside 10% of the London population will have some form of infection in that time, but then basically once we achieve suppression, case numbers go down to a low level, that number is unlikely to increase much beyond that.
I see. And obviously a very serious point is the number of fatalities. Have you made a projection of that? That was obviously one of the concerns that you had in the development of the strategy.
Yes, so not a detailed projection based on the most current data, but we assessed in that report on the 16th of March that fatalities would be probably unlikely to exceed about 20,000 with effectively a lockdown of intense social distancing strategy. But it could be substantially lower than that, and really we need to, that's where real-time analysis and modelling of the type we're doing now will be needed to refine those precise estimates.
Thank you, I'm very grateful. Aaron Bell, I think, has got some questions on some of the recent publications of studies on epidemiology.
Yes, thank you, Chair. Thank you, Professor Ferguson. Just to go on public health interventions more generally, could you, well, you concluded that epidemic suppression was the only viable strategy at the current time. Do you think that is a feasible strategy for the UK, and if so, for how long?
So, we clearly cannot lock down the country for a year. The challenge that many countries in the world are dealing with is kind of how we move from an initial intense lockdown, which is what China deployed, I should say, and now lifting. How do we move from that to something which will have probably societal effects but will allow the economy to restart? As the Chair pointed out, I mean, that is likely to rely on very large-scale testing and contact tracing. It should be stated that the entire world is in an early stage, though, in terms of developing such strategies. China is now it's only been coming out of lockdown really in the most affected areas in the last week. We have yet to see quite what the results will be, the extent to which transmission will resurge. I suppose the most encouraging data is perhaps coming out of South Korea. It should be, people talk about South Korea as if they only did lots of testing. They actually had quite a lot of social distancing on top of that and school closure. So even for South Korea, it remains to be seen quite what will happen when they completely restart the economy. But they have relied on very rapid, intensive testing and case isolation, perhaps more than most other countries, with some degree of success. And so we're looking at that as a model. The UK does not have the testing capability to replicate South Korea right now, but it is likely in the next few weeks we will do.
Thank you. So, bearing all that in mind, to what extent would you say reaching a degree of herd immunity either through a vaccine or through, in the end, everybody having had this, is that the only complete exit strategy for having COVID-19, or is what you just described in South Korea and the report, the paper that Imperial published yesterday on China, are those actual exit strategies, or are they just management strategies?
I think those are management strategies. I mean, the very intensive testing, contact tracing, isolation is still going to have very significant costs, both economic and societal, associated with it. And it's yet up to say we don't know how sustainable this is long term. So the long-term exit from this is clearly the hopes around a vaccine.
Thank you. If I could just ask you about a couple of other papers. You mentioned earlier the one that was reported yesterday from University of Oxford, Gupta et al., suggesting that potentially half the population may have already had it. Could I ask you a few general comments on that and whether it can be squared with some of the observed data, for example, the Diamond Princess case?
Yeah, we don't think it's consistent with the observed data. I'm not sure if the Diamond Princess is a good example because that was a very close community, but certainly even if you take that, then the proportion of symptomatic cases was much higher than assumed by Gupta et al. We also have been analysing data from a number of Italian villages at the MRC Centre in the last few weeks, where they did a viral swab of absolutely everybody in the village at different stages of the outbreak. And we can compare that with sort of official case numbers, people report symptomatic cases. And again, those data all point to the fact that we're nowhere near the Gupta scenario in terms of the extent of infection.
Okay. And secondly, in the Times yesterday, there's a paper reported, it's before peer review, from Professor Thomas of Bristol University, who questions the damage to the economy and whether that's being taken into account, suggesting, I think on his paper, that a fall of more than 6.5% of GDP would in the long run be worse for health outcomes because of the obvious correlations between GDP and life expectancy. Is that any part of your models, or are you just focusing on essentially flattening the curve in the shorter term?
So, I mean, I think that's actually a very important consideration. It sounds very utilitarian in a philosophical sense, but you're kind of weighing up potentially, if we had gone a mitigation scenario, maybe 200,000 deaths versus economic impact. But given the scale of economic cost and exactly those unintended consequences for health in other sectors, I think it's a perfectly valid consideration. And one the government and scientists have been grappling with. We don't know what the level of excess deaths will be from this epidemic. And by excess deaths, I mean by the end of the year, what proportion of those people who died from COVID-19 would have died anyhow? But it might be as much as half to two-thirds of the deaths we're seeing from COVID-19, because this is affecting people typically with either at the end of their lives or with poor health conditions. So, I mean, I think these considerations are very valid. Nevertheless, policy was determined in some sense less by that, which is a valid scientific and ethical debate, but more by the evidence that really the NHS could not cope at all with the level of demand which was going to be seen. And that would have unintended consequences on health of the entire nation in terms of people being treated for other conditions.
Thank you. Yeah, thank you.
Zara.
Thank you, Dr. Ferguson. You've spoken about more intensive and socially disruptive interventions being required to suppress transition to low levels, and that it's likely social distancing will be needed in place for many months, perhaps until a vaccine is available. With the measures the government's already taken, how likely are we to see another peak in the winter, and could this, if at all, be stopped?
So, we think the government's measures now will, with a reasonable but not certain degree of confidence, will turn the curve over, will turn the epidemic from a growing epidemic into a declining epidemic. Whether we get resurgence of transmission depends really on the policy decisions made probably in 3 or 4 weeks' time, and the effectiveness of the measures we put in place to replace the current regime. This comes back to the issue of can we move from a complete lockdown, which almost certainly isn't sustainable for the rest of the year, to something perhaps making better, more use of intensive testing, contact tracing. I mean, I can't give you an answer to your question though. I mean, there will be some resurgence of transmission. The hope is that by deploying more focused policies to suppress those local outbreaks, we can maintain infection levels at low levels in the country as a whole indefinitely. It remains to be seen how we actually achieve this and how practical it proves to be.
And just to follow up, I want to quickly ask about modelling for different age groups. There's been a lot of focus on the elderly, and rightly so, and we've got a policy of shielding for the next 12 weeks. At UHCW in Coventry, we've had the youngest victim, an 18-year-old person with underlying health conditions. So what do your models suggest about the impact on younger people, particularly in light of how much time young doctors, nurses and hospital staff are spending around infected patients and the availability of PPE for them?
That's a good point. I mean, I did have numbers to hand that I could share, but without doubt, most mortality is going to be in the elderly and frail. But mortality from this virus in younger age groups is not insignificant. It's substantially higher than, for instance, seasonal influenza. So whilst the absolute proportion of deaths will be low, we will unfortunately see more of such instances of mortality in younger age groups. And that has clearly informed decision making as well.
Thank you.
Mark Logan.
Yeah, thank you, Professor Ferguson. And just going back to a point that was raised there in terms of, at the moment, seemingly in the southern hemisphere, which is kind of the opposite side to us in terms of winter to summer, already have cases. And to what extent in your modelling and your thinking come this summer do you see higher temperatures having a positive effect on managing the decline of the virus?
Yes, so there's been a lot of debate around that. There's very little in the way of firm evidence. I think it is plausible that this virus will show similar patterns to other respiratory viruses, and that suggests that transmissibility of the virus will be somewhat reduced in summer, but perhaps not by more than 10 or 20%. So that will aid control, but it's not as if this virus could not transmit in the summer. Our best guess is you could easily get a very large epidemic in the summer, albeit it would spread slightly more slowly than it would in the winter months. There's evidence for other viruses, such as influenza, about this. Back in 2009, when we had a very mild H1N1 pandemic, we were seeing very effective and efficient transmission of that virus all the way through to July.
Okay, yep, thank you. And then in terms of regionality, so within the UK, your current study looks at kind of Great Britain on its own and excluding Northern Ireland. So I wonder, can your model extend to the whole of the UK? And then secondly is around some of the research that I've read on this and looking at maps seems to suggest that, yes, in Westminster, where we're located in London, that we have a current higher rate, but in the rest of the UK, there does appear to be hubs of infection, which may be slightly different than other countries, and I wonder, could you comment on that?
So what we're seeing now is really community transmission across the UK, and indeed across the island of Ireland. The reason we're seeing hotspots is, we think, down to different levels of seeding of infection into the country in different areas, really in terms of cases which are coming from outside the country. That's how the infection got into the country. And so clearly we always would expect London to be ahead of the rest of the country. That's the principal destination of most foreign visitors into the country, people returning. And so what we're seeing is a result of that difference in seeding and a bit of random chance. For instance, there's a hotspot around Nottingham and Derby at the moment. We might not have predicted that based on people returning from overseas. It's probably likely, just as in Lombardy in northern Italy, that one or two people came back somewhat earlier, maybe in in late January and started seeding transmission there. It was unrecognised, and therefore that bit of the country is a little bit ahead of other bits which got less seeding. But there is transmission everywhere. I mean, I talked to my parents the weekend in mid Wales, remotest rural mid Wales, I should say, and they've seen a case in their local community hospital. So it is very widely distributed.
Thank you.
And coming to that, of course, that modelling of the whole country, yes, we're intending to roll out models across the whole of Europe and allow policymakers to both to use our model in different settings, and indeed we'll be releasing the model as open source code in the next week or so.
On that point, Professor Ferguson, you said in an earlier answer to the committee that the capacity of the national health system would be adequate, but perhaps not in particular places. Is that a bottom-up analysis or a top-down prediction? In other words, do you know already that particular places will need to be helped out by others?
Yes, I mean, we're producing daily estimates, short-term forecasts of healthcare demand at the NHS trust level, and then aggregating those up to English regions, for instance. And so we do know, and you can see it in the data, you've read the reports, that there are individual hotspots where ICUs in particular hospitals are already being overwhelmed. So, I mean, it's informed by that sort of analysis.
Absolutely, thank you. Catherine Fletcher.
Professor Ferguson, I think the British public are extremely grateful to the work of the scientific advisors, exemplified by yourself, spending time whilst you're still not feeling brilliant answering these questions. So I just want to say a big thank you for taking the time to come in and do a cracking job as well. I'm sure I speak for lots of people across the country when I say that. In terms of the modelling, people are desperate to understand to make sure they can do the right thing. And I've certainly had a lot of questions from South Ribble residents about different rates of transmission. 5 people working in a mechanic garage who are very familiar with each other versus 50 strangers in a pub. And I think it would be really helpful if you could explain how you're modelling those different types of social interactions.
So first of all, I should just be clear that we, very few models, but certainly the models we look at do not model society at that level of granularity to distinguish, 5 people in a garage versus a group in a pub. What we do is try to abstract out those things. So we model, for instance, workplaces. And in workplaces, we represent people who meet every day, or most days, for instance, small networks of people who have persistent contacts. And we compare that with typical social mixing in outside households, outside schools, outside workplaces, which is much more random between people. So we capture some of those essential details without capturing absolutely every detail which would be impractical. I'm not sure if that helps.
Very good.
I can expand.
And very briefly, and then the difference between the big groups. So there's lots of people wanting to understand how risky it is to go to Old Trafford versus watch football on the sofa with your granddad.
Yeah, and I completely agree with how kind of the Chief Scientific Advisor and Chief Medical Officer explained this. I mean, all the evidence we have is that the thing which poses most risk of transmission is being in close proximity with people for an extended period of time. So whether you do that sitting next to somebody you don't know at a football match, or whether you do it sitting next to somebody in a pub, makes very little difference. There's nothing intrinsically more risky about a mass gathering compared with normal social activity.
Thank you.
I have a question from one of our colleagues who can't be here today, Graham Stringer MP, who asks, Professor Ferguson, what is the sensitivity of your model to variations in the incubation period, the basic reproduction number, and the onset and length of time of infectiousness?
So, I mean, there are 2 very important quantities. One is the reproduction number of secondary cases per case, and the other is what's called the various serial interval distribution, generation time distribution. Basically, how long it takes from when I get infected to when I've infected all the people I might infect. And those quantities govern a lot of things, about how difficult the epidemic is to control, but also how fast it grows in time. I should admit that, I mean, we've always done sensitivity analysis in the modelling to a variety of levels of values of those quantities. What we've been seeing, though, in Europe in the last week or two is a rate of growth of the epidemic which was faster than we expected from early data in China. And so we are revising upwards our central best estimate of the reproduction number to something more, a little bit above, of the order of 3 or a little bit above, rather than about the 2.5 level. We don't, I mean, that actually adds more evidence to support the more intensive social distancing measures applied this week, because the higher the reproduction number is, the more intensive controls need to be to achieve suppression of the epidemic. But the current values are still within the wide range of values which modelling groups informing SAGE have been looking at previously.
Thank you. And given that SAGE has recommended an escalation of the response in order to keep NHS capacity, to keep the cases within NHS capacity, are those numbers, those parameters now stable, or would you expect to have to revise them again? And if so, is the reassuring reflection you were able to give to the committee about the capacity of the health system, is that contingent on there being no further change to any of those variables?
So we're getting a better, maybe I'll put it this way, we're getting a better picture all the time from surveillance data, which I have to say is imperfect, but as it accumulates, we understand the patterns of transmission, not just in China, which we were relying on before, but in this country and other European countries better. So I think future changes will be, I mean, undoubtedly parameter estimates will be refined, but the changes will be less than we've seen in the past. Ourselves and a number of other groups are constantly updating models and predictions of both, immediate bed demand in the next few weeks and the likely impact of interventions. But I don't think they'll change to the extent that they undermine the conclusions I've given you today.
Professor Ferguson, we're very grateful for you appearing before the committee today. You've been extremely helpful and informative. And as Catherine said, to have done that when you've recovered from the nasty experience of having gone through the virus is a real testament to your professionalism and your resilience, and we're very grateful. Thank you very much.
It's a pleasure. Thank you.
Thank you. We'll just take a break while we organise the next witnesses.